Had a huge interaction in London with oral and maxillofacial surgery, which goes back to about 2005-06, when Liz Jones, the postgraduate dean, and I got together and talked about a very positive move, that we needed oral and maxillofacial surgery to be in surgery for various reasons, but that we didn't want to lose anything. So for about 4 years, I think, we worked together, she and I, but we were gradually moving oral and maxillofacial surgery across into the surgical side of the deanery in entirety. And with that, we took some of the OMFS jobs, particularly at King's, and put them into the general surgical training for the core surgical trainees, which needed a little bit of fiddling around with, as you might imagine, because of the dental side of it. But it worked, and it started to work. And what we're now seeing out of that is a significant number. I don't know what the exact percentage is, but to my mind, it's looking like something about 75% of the trainees that go in and get access to the OMFS core training jobs, they're actually positively then going off to study dentistry. So that's something I'm going to give you a little bit of a talk about. And the absolute health warning here is, this is my opinion, because I know I'm going to rattle some cages, which is my job as head of school. So Mark set me this target to do in 15 minutes. I'm supposed to be, from a medical perspective, trying to deal with 3 questions. What do I think will be the pattern of training in the future? That's all it said. It didn't say OMFS, it didn't say anything else, but I'm taking it really into the OMFS arena. How do we develop an academic base? Well, there's been a fantastic introduction and a case for the need for it, and I'll just lead a little bit more on from there. And, of course, this old chestnut of what are the main problems. You can't do anything in life unless you're prepared to have a vision and work with it. And that means, you know, accepting opinions that may be different. As soon as you put your head up with a vision, you'll have a whole group of people that hate you. So you have to have that sort of personality where you can live with that. If you don't express a vision, everybody will like you. Well, everybody might hate you, of course, but everybody will like you and you'll have a very boring life. So if you're in postgraduate education, the visions have to be very, very high. You have to look at world-class education for world-class healthcare. We cannot separate service and training. Training is not tacked on to service reconfigurations. Since 2008, I've done nearly 260 departmental visits. Each one takes 4 to 4.5 hours. So you can see we've invested huge amounts of time in going around department to department. We have made more changes in service reconfiguration by talking about failures in training than have been made by anybody. Just a month ago, I went into a trauma and orthopedics unit. When I came out, and here we are a month later, they have already advertised for a new consultant post. The second thing is that you can only strive for excellence. You may not quite reach it, but you have to aim for excellence. You cannot take mediocrity. And the final thing that you have to accept is that anybody in this game, whether you are from the dental perspective through to the OMFS perspective, or you know, dealing with level 1 or level 3, as we've heard, you are by definition a leader. Even if the only person you're leading is a dental nurse, you are a leader. And if you're in an operating theatre, you are a leader. You have a team around you, anaesthetist, and when that patient, if it ever happens, I'm a vascular surgeon, so sort of catastrophes in the operating theatre happen, not frequently, but they're usually unpredicted. When that patient arrests, everybody looks to you. You know, you're the leader, you're the person. You may delegate to the anaesthetist under cardiac arrest. So we are producing the clinical leaders of tomorrow. 3 elements to training. We've heard about knowledge, which is quite right. Knowledge is tested by you have a curriculum, you have exams at the end of it. It's an essential part. I don't agree that we shouldn't have qualifications, but they're not the most important thing. Skills is terribly important. We are lost. Trainees are lost. Trainers are lost on the relative importance of skills. There's only 10% of the population you can't train in the skills. Judgment. That is the most important thing. When to do it, when not to do it. If you do it 90% of the time it goes very smoothly, no problems. What do you do when it goes wrong? That's what distinguishes the good from the bad. Absolute knowledge of anatomical variance, so knowledge and judgment are brought in together. You suddenly get, whoa, a bit of bleeding and it's an aberrant vessel. But look at the final sentence, and that is about excellence. Good enough is just not good enough. So there has to be a continuous drive to elevate everything. I'm just going to talk for a moment about the model we've set up in training in London, and this is where you'll see a little bit of training issues and a little bit of academic issues. This is slightly based upon the initial discussion, which was where do you see it 10 years' time, because you'll see I've got a core year 3. I make no apology for this because I keep rattling away at the Department of Health. 2 years of core training is not enough. It's enough for some of our trainees. Now you can guess what the figures are. The realistic figures are about 25 to 30%. 1/3 of them, top third, will progress. Probably they could progress after 1 year of training. But the vast majority need a little bit more time. That may be partly them because they're slower developers. It may be the environment that they've been in. If, like me, you believe that part of core training should be to do intensive care, if you've done 6 months of intensive care, of course you've missed out on going to the operating theatre. So, you know, there is a balance here all the way down the line. So I make no apology for it. Actually, CT3 could be booted out if F2 became part of core training. And I'm just waiting for John Collins to come back in 2015 and do the report he should have done, which he fudged, I believe, because I don't personally believe in 2 years of foundation. But there we go, and the Department of Health is currently trying to take every single surgical job out of F2 and put them into psychiatry and general practice. And I've resisted that in London, and I've got together with the foundation school head in London, and we have actually positively opposed that. We're going hell for leather to get more F2s. But there we go. Okay, so what do we then put in? It's absolutely essential those big lines are appointabilities, because some people unfortunately have a wish to be in a skills-dominated profession but actually don't have the skills. They may have the skills, but they may not have the psychological approach. They may not be prepared to dedicate the time. There's an awful lot of time and dedication. You can't look at your clock at 5 o'clock and say, I'm going home. If you want to operate on somebody, you've got to see them before the operation, during the operation, and after the operation. You have no right to appear as a technician, merely do a procedure and abandon them. So there we are, and then I put some little arrows in for research. Some of those represent when people do research, and some of them represent where I'd like them to do it. So you can see some people, I'm not talking about dental here, this is the person who's done medical training. They may do research between foundation and core. That may be an opportunity. Opportunities come along rarely with grants and things like that, and someone offers them an opportunity. They may have done it intentionally because they couldn't get into CT1, which is highly competitive. I'm talking about London at the moment, although South West did very well. but only 5 deaneries managed to fill core training at the first attempt. And there's still vacancies. They've gone into a second round, which is very worrying for surgery, because it means we haven't got enough people coming in at the bottom. You need competition ratios. So they could do research there. They could do research in that CT2 level. In other words, they finish core training as it stands at CT2, can't get into higher training, decide to go off and do research to build up their career. They're likely to come back into it. Let's not call it a CT3 job now. Let's call it a post-core fellowship, because CT3 doesn't actually exist. And they're trying to enhance their skills to get into that higher training. Those last 2 blocks are the one that I sincerely believe in. Because I think for surgery, doing research earlier is too early. And I think what you need to really be doing is surgery in something that you enjoy and like. And it's going to become your lifetime work. It'll undoubtedly modify. In other words, it's no good doing a PhD in orthopedics if you wish to be a urologist. But this is what happens all the time. And what you've learnt from your academic work is fine. You've learnt academic methodology, but it's not, a subject that you can translate and carry on. So I personally, with that or between, would suggest that the majority of academics should get into ST3, spend a good year of concentrated clinical training, make their decision about becoming an academic, come out to get their PhD or MD, and then go back. Just to show you all the other things that we've thrown in, anatomy, I think the medical schools have absolved responsibility for teaching basic scientists. Needs to go back to them. I'm vilified by our medical schools, except the anatomy departments. But we have taken anatomy now to be a postgraduate training. So all our trainees get half a day a week of anatomy, taught basic science actually, applied clinical physiology and pathology. I put MRCS there. Most of them have got the MRCS and they're doing the anatomy post-MRCS. And then in core year 2, they go back to do the anatomy demonstrating for the undergraduates. Two levels of thought here. The first one is it enhances their anatomy understanding. They have to do 30 sessions in the year, and we define a session as 2 hours. That's just because that's how the undergraduates are set up. So it's 60 hours of teaching. Who has ever been taught to teach? The absolute arrogance in medicine, when I sit on interview committees and you say to someone, are you a good teacher? And they say, yeah, I'm a really good teacher. Oh yeah, how do you know? We are not taught to teach, and yet we are expected to pass it on. So that's a big part of that CT2, learn teaching, but you're learning anatomical skills that are relevant to your part of the profession. So whilst you may be in a department, okay, you might be doing a bit of thoracic teaching. You're not teaching about the sole of the foot or the leg if you're a head and neck specialist, because you pick your sessions. And the orthopedic orientated trainees pick the sessions that are going to be relevant, arm, limb and whatever. So that's how it's shared out amongst all our medical schools. 2 of our medical schools have gone back purely on this initiative to using cadaveric dissection and prosection, where in the past they'd actually abandoned it. So it's been a huge initiative, and of course the best thing once you get to that level is you've then got the hierarchy of the university saying, oh, you can't stop this, it's got to happen. Took a lot of persuading the units to release the trainees, I have to say. And of course we've got that little word simulation in there. I'm very pleased in London that we've now got simulation built into every single one of our 9 specialties, including OMFS, which is being run through St George's primarily with a head and neck frozen head course. So here we come. Let's get into the contentious stuff. Now I've sort of softened you up. Mark's first question, what will be the pattern of training in the future? Well, I believe very clearly OMFS is a medical specialty. I've got no doubts. I don't like the word medicine, I think it's a surgical specialty, but I have to call it medical. So I do believe that the route in should be medical first and then a shortened dental degree, but flexibility is the most important thing that anybody can ever have. If someone has gone into dentistry first and done a full dental course, but has decided because of the environment that they would quite like to continue, well then so be it. But I don't think that the future, you guys spend too much time training. So we've got these shortened dental degrees, but I think they need to be even shorter for the OMFS people. I don't see why we can't write a curriculum that is absolutely relevant to OMFS and delivered in 2 years, and we could deliver it in postgraduate training. So it could be done on a, God forbid the word, of apprenticeship type of day release sort of thing, you know, going right back, but we could do it for those people that wanted it. Now the question is qualification, because everybody comes back to qualification. Well, diplomas, degrees, whatever it is, I don't really mind, but that is a point of debate for the future. I think there needs to be separation of medical from dental, but there needs to be teams built. So you are an oral surgeon or you are an OMFS surgeon, but you both work in a team. And in my specialty, the equivalents would be a vascular surgeon and an interventional radiologist. You know, we work in a team, we've got complementary skills, but we've got different interests and different ways that we've got to where we are. I am absolutely sure in 10 years' time that there won't be a specialty of OMFS. You may go through that route to training, but it'll be head and neck. And it'll be a combination of ENT. So the pure medical person may go through an ENT route, but of course they won't be touching the dental aspects, and the person dealing with the dental aspects will have come through this additional 2-year training program. I did it, if I was giving this talk a couple of years ago, I'd have thrown neurosurgery into that. No longer, because neurosurgery has taken orthopedic spinal surgery. The cranium is now really about radiologists embolizing aneurysms and somebody doing a stereotactic biopsy. So, I mean, it's a bit cynical, but do you know what I mean? I think neurosurgery is spinal surgery of the future. So I think it's the ENT guys, they've got the specialty, you know, the airways and, you know, whatever, as an interest, and you've got the other areas. So here we are. How do we develop an academic base? You can't develop this comes back to the whole thought processes of have a vision, have an ethos. The two groups in this world that I have the most admiration for leadership is professional sport and the military. And in both of those there is an ethos. People hate this because in medicine that ethos used to be which medical school you trained in or what hospital you worked at, and you know, I'm from St Mary's and all this sort of rubbish. But you need an ethos, and that ethos has to come back to the trainees. With due respect, I'm not quite sure who's trainees and who are trainers here, because you people have been training so long. It's just a great group of people. But talking to the trainees, you have to take responsibility for your training. Everybody throws that down your throat. You have to go and ask for the work-based assessments. You have to be there. You have to do it. But you have to take responsibility for your career as well, and training. And I would come up with this thing, that all surgeons working in academic health science partnerships, they're not centres anymore, of which there are 3 in London, at Imperial, at UC and at King's, and then there are 2 outside of London at Manchester and Cambridge. No Oxford, I'm afraid, but that will undoubtedly come. Undoubtedly? Perhaps come. But academic health science partnerships, I don't think you should work there unless you are an academic in the future, 10 years' time. And the same with universities. So if the future of oral and maxillofacial surgical departments is based upon a sort of hub and spoke mechanism, but you've got the academic centres and the university training centres, and you've got the DGHs, if you're not academic, you will only work in the DGH environment. That's my belief. You've got these three areas that every trainee has to cover, and this is where you take responsibility for your career. Academic research, academic education and training, because many of our academics forget teaching and training. They're in for a shock when trainees are paying 9,000 quid a year, because the trainees are going to start naming and shaming. And management. Now, all that happens here is you work on percentages. If you're very, very good at academic research and you enjoy it, that may be 75% of your time. I mean, make up whatever figures you like. You may spend 10% of your time training and teaching, but you must spend time doing it. And I'm not talking about being a clinical trainer, teaching someone to do an operation. I'm talking about supervision, I'm talking about didactic lecturing, putting yourself about. And then, of course, you may only have 5% of management. Of course, you might be the other way. You might spend 75% of your time doing the teaching and training, and you become a postgraduate dean and undergraduate dean, whatever it might be, but you still have research. I've been in education now full-time for 26 years. I mean, I'm a clinician, but I've got 140 publications. I produce 1 or 2 PhDs each year. Like Mark, grants are hopeless. I fund most of mine from soft money, but you have to do both, and then some will do management. Grow your own is the answer to the question, I believe, from our previous speaker. I don't think there is a future for academic heads of departments. The universities don't want them, they're costly, they sometimes make mistakes in the appointment. And surgeons in general tend to develop slowly, so that you find 10 years into a job, you've suddenly got somebody that you never thought would do anything academic, who's suddenly got a research interest and is producing publications and working collaboratively. This is what we've done. Now, you've heard about the academic clinical fellows, the academic clinical lecturers, senior clinical scientists and whatever enumerated in the previous talk. Mark Walport was a colleague of mine who moved out of medicine from the Hammersmith and into all sorts of things, but this was the scheme he came up with, the NIHR academic route. And of course they went from it being a national thing to a university thing. So it's divulged to the universities, and then clinical departments apply. Well, of course, immediately I spotted this a year before it happened. Surgery wasn't going to get a look in. You know, the white cells would get 50, and the red cell would get 50, and the platelets would get 50, and the surgeons would get 1. So what we did in London, we started to convert NTNs into academic NTNs by liaising with NIHR and backing funding. So what I did was produce the national training number with its 100% Maydell funding, and we got the trusts to produce 100% funding from their trust fellows, and we put the two together so that we could have 50% clinical and 50% research, exactly the way that the academic clinical lectureships worked. And of course we couldn't call them ACLs, so we called them clinical academic lecturers, so they're called CALs. And then we looked down at our 9 specialties, and of course we had a big rump end of general surgery and TNO, well not TNO not so much, but general surgery, ENT. They still had lots of people with postgraduate degrees. Mark came to me and said, how the hell am I going to get anybody into OMFS, because we don't have anybody who does PhDs or MDs. So we said, well, all right, we'll negotiate with NIHR. To get a CAL, you have to have a training number, So it's not a backdoor entry into training. You have to have already achieved that, and you have to have a postgraduate degree. So we got NIHR to agree that we could have a little bit of time where we could actually let people do their postgraduate degree having got their CAL. And actually within 2 years, we've suddenly got 2 or 3 people come out of the woodwork who've actually got the higher degree, and we're probably now going to be building in more and more. I'm talking about OMFS there. We've got 65 CALs throughout London now in the various specialties. And of course my role in the centre of it all is to make sure that you've got big teaching hospitals and, oh, we'll have 10 of these and 10 of those. You can't overproduce academics. But coming back to the question about departments, we got King's College Hospital, for instance, to agree, Robert Leckler, who's the vice principal there, agreed that we could have 2 CALs in trauma and orthopaedics without an academic department. So how do we do this? We get the professor of OMFS to act as a nominated internal supervisor at professorial level, and we get the professor of surgery from UCL to be supervising the academic building of an academic department at King's. So it's a fantastic, and an agreement that there will be senior lecturer posts afterwards. Here's some of the problems as I see them. I think identity is a big problem. What do you want to be? Do you want to be a dentist? Do you want to be a doctor? Do you want to be a bit of both? Do you want to be 80% one, 20%, 50-50? And this concept of registration with the General Dental Council is, you know, I think a problem. Particularly it'll become a huge problem if anybody took up my thoughts of 2 years of dental training that was appropriate. I think the length of training is ridiculous. I think I get it thrown at me all the time about the length of training in surgery in general. Why aren't we doing what the Americans do? From the date you get your qualification to the date that you're trained is 4 years. And we've got a minimum of 8 built into our system already. They do it in 4 to the same level. But of course, every single person in the States is postgraduate. And this is the other big thing. I don't believe that undergraduates at 18 are mature enough. They're mature enough to learn the knowledge, but they're not mature enough to be doing medical training in this day and age if you're going to accelerate postgraduate training. So we need to move more and more down that. Interaction. Well, service interaction. If you've got OMFS, well, I mean, we've heard a discussion about dental people learning in secondary care. If they learn in secondary care, absolutely fine. I'm all for that, but they need a medic with them. And I think the same with the OMFS side, that if you're medically qualified and have got limited dental work because you haven't gone off and done it, in other words, you've done your OMFS house SHO job, but you haven't yet done your dental qualification, you're going to need a dentist with you. But to then start having interactions with other specialties, which is hospital at night, where you're, you know, maybe covering orthopedics because it's trauma and whatever, this takes a whole lot of, you know, this is a problem, I think, for OMFS. And of course, the other thing is the training issue. I do personally believe that ENT and OMFS should get closer and closer together, and actually at higher training, they should swap a lot more. And then, of course, we've got the biggest thing of all. Are you a trained generalist or are you a specialist? Where do people want to be? I would say in 10 years' time, everybody will train to CCT as a generalist, and that will be it. Now, there can be debate about whether we have junior consultants or senior consultants. However you want to label it, there will be the training. It's happening already. You finish your curriculum, you come out at CCT, you are a generalist, and then a lot of the specialist training is done on top of that. Quite happy to take questions.
I forgot to tell him not to be controversial.
No, you didn't. You told me to. I've held back, Mark.
Okay. Can I just preempt this by saying that Nigel's been a huge help to us. He's thinking laterally. He really is working with us. So please, anything you shoot up here, make it soft so you don't go down.
No. I'm a big lad. Come on.
Yeah.
I'm amazed protect Nigel Stansfield. He doesn't need any protection. I've seen him before. You know, well, I was very interested in a couple of things that you said. Postgraduate, making the second degree of postgraduate training, because of course, with pensions, with the time that people are earning, the pay protection issue, if we could have that second degree labelled by the NHS as a part of postgraduate training and recognised as such, then presumably we could then, it's a short step to have it as valuable for pensions and valuable for pay protection into the next thing. So I loved your comment about that.
Anything is possible.
Yep, great.
I got the funding for the anatomy and got it established. It's been running for 5 years. It's a postgraduate training course now. So anything is possible.
Yeah. That's the second degree. Yeah. The other thing is I agree entirely with your view that medicine, the medical degree, and to a certain extent the dental degree, is an apprenticeship. It's not like a university degree where you're doing a pure subject and you come out and don't have a job to go to. You're being trained to pursue a career. And it's wrong to expect people at the age of 15 or 16 to be making that final decision. Everybody at 15 or 16 believes in doing things for the greater good. But when they come out of medicine at 23 and they see people with less academic qualifications at 18 earning 3 times the amount of money they've got, they're very disillusioned. So I thought some very good points there. Excellent. On the ENT side, why not make it, and I agree entirely with that, but why not make it that both ENT and oral maxillofacial surgery and plastic surgeons who want to operate in the head and neck, merge them, create a head and neck specialty, but everybody has to have both a medical and dental undergraduate degree to do that.
You could do that. I mean, but that would come back to this 2-year, very appropriate training qualification. But I did mention flexibility. I think you should always be flexible, and what you have is a plan A and a plan B. You don't make it compulsory. You say, it's there, we're giving you the opportunity to do that second two-year degree. If you don't want to do it, then you know what your limitations of your job planning will be.
Nigel, can I say that one of the things that I found very useful with the way you've designed the research training and the SPR thing is that it's so easy to go off and do some very high-powered research, and then when you get back into clinical training you have to drop it, and then to pick it up again 5 years later it just doesn't happen. And to be able to do it as part of your final training means that as you walk into your consultant jobs you're up and running and you're already working with these departments, your programs are already established. And I think it's fantastic in that position where you've put it.
It wasn't my remit to talk all about academia, but we're talking about 50% clinical and 50% academic running through a 4-year program. The idea at the end of that 4-year, you already have your PhD or MD. The idea at the end of that 4-year program is that you get a clinical scientist award if you wish. Again, it's a guess. What's the proportion of the clinical lecturers that you set out with? Will it be 1 in 3 achieve it? Will it be 1 in 5? Will it be 1 in 10? I'd like to be optimistic and think it'll be 1 in 3 because we're going to be very tight on recruitment. I think in reality it may be 1 in 5. And that's where our balance, and it's our balance, it's me helping as a dean with a specialty. How many do we need? I've no idea. We can guess in London.
Okay, Rob, yep.
Just a reflection to everybody about where we've got to at this level. And it hasn't got to this level by chance. It's been with, as Nigel pointed out, vision and close cooperation with the dental postgraduate deans and the medical postgraduate deans. The trial centre at King's has, I'm on call this weekend, I've come away, last night there was a dentally qualified SHO who's doing medicine at the moment. This morning is a CT1. They work synergistically with each other. Those individuals, and we have them represented here today, have gone on to do a shortened dental degree with a view to do an OMFS. 5 years ago that would not have happened, and those individuals have already been appointed not only at the ST3 level into OMFS, but also into clinical academic lecturer posts after having done 2 years in OMFS. So my own view is it's about flexibility, it's a continuum of training between dentistry and medicine, and it is the flexibility and recognising people's competencies and subspecializations, whether that be in oral surgery or whether that be in OMFS surgery, but it's a continuum as a whole concept of OMFS.
Yep.
Hi, I'm Alex Goodson from London, and so I want to say it's a very, very interesting talk. Myself and at least 2 other people in this room have come through core surgical training in London, finished in 2011 and started on the short-term dental degree. And what you mentioned about the few people that had exposure to max fax during surgical SHO jobs, a vast number of us have gone in to do our second degree. And it's a point that I think probably BAOMS should pick up on, is that even a little bit of exposure is a very exciting opportunity for a lot of people. The group of us at King's have published a paper this month in The Surgeon looking at the awareness of oral and maxillofacial surgery amongst medical undergraduates who are in their first degree in medicine. A huge number of them have a great interest in the specialty but have zero exposure to it. And then we looked at 2 large medical schools in the UK for that. So should we get the opportunity to expose people earlier on, I think we'd have even a greater effect in terms of recruitment into our specialty. And just a second point I would like to mention is terms of flexibility. I think that is key in terms of attracting people into oral and maxillofacial surgery, is allowing CALs and allowing research to be incorporated into our training from SC3 onwards. And yes, we probably will have to do it in a quicker period of time. We will have to do PhDs or MDs in a shorter period of time than you might do in other specialties, but I think we need to have some flexibility, and not only in the London Deanery, which has been very accommodating, but I think throughout the UK it's essential that we can do research opportunities during the specialist training.
Good. Very well.
Nigel, I really enjoyed your talk, and I would agree flexibility is a key, whether it's a graduate going from medicine or graduate going from dentistry into OMFS. As our previous comments have said, we're both at King's, and I think they bring different skills coming from the different pathways, and it's quite important to have both. I have some concerns about a 2-year program for dentistry for the medics, because they get so much crammed in the 3 years. And certainly, with the scope of oral and maxillofacial surgery, they probably need those 3 years if they are going to continue doing the scope of work we are all doing. But obviously, if the scope of oral and maxillofacial surgery changes for the future, then I guess that could be reflected in a shortened course.
Sounds like a bit of a love-in with King's here at the moment, but can I just... I trained at King's as an SO, by the way, which is how I got to know the dental side, because I knew John Langdon very well, and his predecessor, Sowry and that. I taught them all for the FRCS. But coming back to that, the debate is a 2-year course. Maybe it only needs to be 1. There you are. There's a comment.
Remember, these are ideas that are floating out, but we're looking 10 years ahead. Nothing's going to change straight away. It's where things lead and move. Yeah.
I'm Max trainee and trainees rep. Just going back to the model you suggested, to expand on the last comment, I think if I was to, I'm trying to put this softly, but if I was to feed that back to the trainees on our forum, I think this would be seen, this your 10-year sort of like view or plan of the future would appear as though that would be the death of our specialty. I mean, if we put down to sort of a group of people who are part of a head and neck unit who have just done a 2-year Mickey Mouse degree, and therefore the people they can take the teeth out for us, then I think that sort of values what our specialty stands for. And I think that there's a lot more to our specialty. We should forget the people who have actually done dentistry, they understand the mouth, and they are the ones who actually build the specialty. And if you travel around the world, which I've done, I've been to many units, I think the level of sort of respect that our, the UK trained max fax surgeon has around the world, I think would prove that actually we probably do something wrong, something right, and we should probably try to build up on that rather than try to deconstruct the whole thing and start from sort of the other end.
You sure you're a trainee?
Yeah.
Are you not a cynical consultant?
But I'm about to
Coming from general surgery, which I do, okay, when I was working with John Langdon and Sari back 30 odd years ago, 35 years ago maybe, when I was the senior registrar, John Langdon was trying to convince people to refer him parotid surgery and salivary surgery. That was general surgery. It wasn't even in ENT, let alone OMFS. And he started to get referrals, and we all encouraged it. I don't think head and neck surgery has a future in general surgery, and I tell all our trainees that. Endocrine surgery, salivary gland surgery is going to head and neck. Now it's up to ENT and OMFS to decide whether they're going to place it, you know, or they become a single specialty. I'm a vascular surgeon. A year ago, we voted to leave general surgery. Time changes. Look at the last slide that I put up. Modernization. And 10 years seems very quick. But I tell you, in 10 years' time, the health service, training, the specialties are not going to look very much like they look at the moment.
Yeah, I appreciate that. The point I was making is, I mean, I've gone through all this really long training, and I understand, you know, the frustrations, you know, I guess almost every year. But the point is, I think there's ways to make this a bit shorter. I know following the BMED peer review, actually our training, if anything, has got longer. You know, we still, for God's sake, we're still doing 2 years of foundation training. There are ways to shorten the training and still keep that core of dental background that we, but we do, and not really just divide it down to
redevelop the course. It's just hearing views of how we're going forward. We're not going to.
You can have a big argument over lunch or whatever, you know, coffee, beer, or whatever you go and do.
Yeah, can we end this London loving then, please? Because the northern counties have a...
Yeah, let me guess where you come from. I've got a West Country
I'd
accent.
suggest that, you know, I think what you've said is very, very cogent, and I admire the sort of fortitude that you've gone through with it. What I suggest the trainees in a specialty want to know is how is their training programme going to be for the future? And we've looked at lots of different options. Until you have clarity, people will not choose it as a surgical discipline they want to go into. And out of those who do choose, I think they will then be struggling to motivate themselves to go into the academic side. So I think we need a solution to the training conundrum, and as soon as possible, and ratified, and across the whole of the UK if possible, for clarity.
I agree with you. I think decisions need to be made, and sometimes the decision makers have to make the wrong decisions. You know, I mean, don't have to, but sometimes they do, or it may not be universally accepted. But I think the important thing is that this entire process forever will be evolving. It isn't going to be just, oh, right, here's the 2013 view, right, that's it. For the trainees, we have to give them an assurance that when they enter training, they will have a 5-6 year period, depending upon what specialty it is, where they know what's going to happen. But what they must do in 6 years is such a short time. They must take responsibility for their career, because they must be looking ahead. They must be talking to people. They must be coming to people that are decision makers. You know, what is it going to be like in 6 years' time? Workforce planning is an oxymoron. You can't put those two words in the same sentence because you will always get it wrong. There has to be something, though. You could rename it something else, but you've got to workforce something, but you can't plan it. If, as I stated when you were speaking, that I firmly believe in the separation of trauma and elective, because it's the only way you can run the elective service, because otherwise you just don't have any beds. They're full of trauma cases. If you're going to do that, you're going to need more. We're going to need more consultants. And like when the Department of Health, it's a pity Bruce is not here, but like when, or is he? He crept in. But, you know, it's a pity that the Department of Health, when they put about these acute services reviews, and they've said we need a 7-day week, not a 5-day week, and you've got a higher chance of dying at the weekend. I sat on that panel for London and said, extra 2 consultants in every specialty doing emergency work. Great for the trainees, so don't believe a word of the fact there aren't enough consultant jobs out there. There are going to be, because we've now got a drive to make it a 7-day week. You probably didn't want to hear that.
Can I ask you
question to you as a vascular surgeon, and in oral and maxillofacial surgery, there's a lot of patients who would have arteriovenous malformations of the head and neck. And in my training as a house officer, some of the vascular surgeons I worked with were able to do what may have originally been interventional radiology. How, as a specialty, did you move into that skill set?
Well, we haven't fully. It's a fudge. Many of us believe that your skills are based upon your interest. So if you go to France or Germany, you will find vascular surgeons who have gone full-time into intervention. So they're now basically interventional radiologists who have an FRCS. People that dabble in things don't become good at any of it. So if you dabble in the radiology and you dabble in the surgery, you won't be really good at either. So specialization is bound to dictate you have a vascular unit, they take over the endovascular, and then they split up into endovascular surgeons and open surgeons. You're just renaming the interventional radiologists and the way they trained. I'm not going to talk about the concept of congenital vascular malformations. I'm not going to talk about it.
Can I ask Jonathan, with regards to the academic part and training going on, how can we keep the singly qualified academic surgeon and the max fac academic surgeon so that they don't separate? A little bit at King's now, we sort of separated. Is there a way that in the training system you can try and keep them going? I mean, Judith, this is also, part of, we're tending to separate. Is there any way?
Yeah, I'd like to make a comment. Actually, I'd like to ask another question first of all. Why do you bother with a dental degree if you're just going to try and do a 2-year fudge? I mean, you're not going to get enough credit points to actually make it a degree. Why bother? Why not just, open up and say, okay, we're going to extend the training, and part of this will be an apprenticeship, which you don't get a degree for, but actually in some way certifies you to pull out teeth or whatever bit of oral maxillofacial surgery you're going to do.
Totally agree. Bring it down to naught. We've got from 4 to 2 to 1 to naught in 3 questions. I do totally agree with you, but unfortunately you have a regulator. And I don't think the GDC will buy that as a single step. Are you with me? I think it's hard enough. I think what we have to do is sell.
Yeah, I'm just trying to remember what doctors are actually licensed to do. Because
not take teeth out anymore.
Is that right?
It's absolutely, it's reportable now to the GMC.
Okay. Right.
So, whereas my degree actually says I can.
Yeah.
As a, I'm sure those of us with grey hair.
Okay, so Mark, I actually think, and we've got some people going through, and I know there will be another one. Not everybody wants to be an oral maxillofacial surgeon who has done medicine and dentistry, and we've certainly got someone who I think will, for various reasons, has made the choice. Actually, I don't want to commit to all this stuff, but I am trained. I'm qualified medically and dentally, and she's got an intercalated degree with a first-class honours and all the other stuff, which just adds to the length of it. But she's made a conscious decision. Actually, she wants to go into oral surgery, and she'll be an academic oral surgeon. And maybe that's the model. Maybe that's the model.
Well, the model also, just extending beyond that, is that you need teams. You've already described it about grants. You need the oral histopathologist, and there's a whole group. So the oral academic, the academic oral surgeon, the academic OMFS, should give the lead to the clinicians and actually get together. That should be where the lead comes from.
Patrick.
Just a comment and a compliment. I know I don't give you too many of those on a regular basis. But I think one of the lessons that I learned both from being involved in training in London and your talk is actually about sometimes recognising that the wave of change or the political philosophy or what the medical schools think is important to train doctors who want to be surgeons at present might not always be right. And sometimes your responsibility is to use your skills and resources and your wisdom to find a way of working around that obstacle for a time period until people realise that theme or enthusiasm maybe isn't the right way to be doing things, and they come back in touch with you. And I think just for the trainees in the audience, because there is a lot of changes going on at the moment, and the bottom line is probably looking after patients well is what everybody wants to do.
Patient safety is the first. That's who we're all looking after.
And sometimes you have to recognise that you just have to stand while the waves are crashing for a little while, because the tide will maybe move in a different direction at a later date. But have the vision to realise that what is important.
I think that's absolutely right, Patrick. The other thing is always to look at whatever change is going on, and forgive me to the trainee rep at the back, don't be cynical about it. Look and see what opportunities there are.
Yep.
If this change went ahead, what could we get out of it?
Yep.
Yes, you could save money by bringing services in together. Don't let the Department of Health have that money.
Yep.
Have it yourself. That's what I've done with our CALs, because they are protected jobs now. They're university jobs, basically. So Mark's CAL, at the end of 4 years, 3 years down the, after, we'll be recruiting the next one. That doesn't happen with a Walport Fellowship. You've got to go back and apply for a grant, you see. This is the thing, this is why I would recommend thinking about, we'll save some money, but we'd like to keep it.
So that was, sorry, I'll add the other compliment. It's not just about spotting the change, it's also about catching the wave as well.
Okay. Yes.
Catherine Allen, trainee. I just wanted to say, have you done...
Not from King's, though, please.
Yeah,
Oh,
after doing the
I knew
3 year
you were.
shortened dental degree myself, I can proudly sit here and say that I hold the same qualification as my younger counterpart who's been through 5 years course.
Yeah.
If you shorten the dental training even more, you might run the risk of getting an inferior dental degree. We can now stand in dental schools and taking something unique in our specialty in the UK.
Yeah, you might. I mean, that's a fair comment, but let me say, when I trained as a registrar and a senior registrar, it was a 17-year training programme. I'm fully trained as a paediatric surgeon, as well as a general surgeon, as well as a vascular surgeon. And I was only a year away from completing training as a urologist. I did so bloody much of it. I don't look at any of you and think, oh, you've only done 6 years. I know that you get consultants who say, in my day, you're not as good as we were. Of course you're as good as they are. Just haven't had the exposure. So I wouldn't hold that. Stand up. Hold your head up.
Rory,
I can move you away from London slightly to Nottingham, if that's all right. I'm a core trainee. I'm a core trainee up in Nottingham, and we've seen that doing.
Sorry, is that core dental or
core surgical?
Core
training.
everything. Yeah. Okay.
And we've seen that doing Max Fax as a core surgical trainee has a high conversion rate to people wanting to train in Max Fax. But I've come up against a bit of a brick wall up there in trying to get any core training any Max Fax into my core training. And some deaneries are better than others at accommodating Max Fax trainees. Have you got, on a more practical note, some advice for trying to get Max Fax into core surgical training?
Yeah, very clearly. It's the clinicians. That's what it is. If you can convince the clinicians that there are hurdles, because they have to go back, I'm pointing at Rob here and Mark, they have to go back and convince their cynical old men back in the department to do it. So once you've sold it to the clinicians, so that's not a job you can do, but the only thing you can do is find a clinician and really push them and help them, and go around and get questionnaires off the trainees that give you facts. Facts are power, data.
Okay, last one.
We have been exercised by the title of our organisation for many, many years. It's a very long title. It's not understandable to the general public. Oral and surgery is, facial, but maxillary isn't understandable. We recognise that there's a longer undergraduate training programme. We're looking at innovative ways of ensuring that people can do higher degrees during that training programme. You've illustrated one way with the National Facial and Oral Research Centre. We're hoping to do epidemiological studies, mining the data, so they can do it without taking time out, blocks out. They can do it in their day off over a 7-year part-time PhD. maybe even before they start the second degree and continue through the second degree. So we're looking at all these things, but through it all, we have gone back to our membership over and over and over again, as recently as last year, and said, do we drop the title oral? Do we forget about dentistry? And going around the country and talking to individual units privately, they've all said, we want to retain oral and we want to retain dentistry. Now, there are a lot of junior trainees here. Maybe we could have a show of hands again. Do you want to discard oral, go along the Stansfield route, have no give oral surgery to oral surgeons, simply dentally qualified? Do we want to, or do we want to retain dentistry? I personally feel that dentistry is valuable, but you know, we've got a lot of junior trainees here. What do you think? Do you think we should forget about dentistry, make it a medical degree, only medical degree, and do maxillofacial surgery? What do you think?
Retain it.
Can I add one thing to that, though?
Drop the maxilla, yes.
I think
Drop the maxilla, yeah. Facial surgery, yes.
an
facial.
enhanced medical degree. I think you have to have a medical degree plus. That's the Stanfield model, not just a medical degree.
Well, what do people feel? What do you
No,
feel?
but Hutch, what I'm not trying to do here is drive this in terms of which way. Changing names of things is not going to happen.
No, but it's
It'll go-
getting rid of
it'll
dentistry.
It'll go very
Getting rid of
slowly.
dentistry. Nigel said that, and you know,
But
that's been said.
No, Nigel's raised
Yeah,
options.
absolutely.
What I'm going to say is that if dentistry is dropped, it'll be a number of factors like financial, the way things are happening. It'll drive it till when you bring up a subject like that, people say yes, it's obvious. You know,
But we're coming back to Patrick's thing. What instead of you're saying things drive you, outside forces driving it. Thanos has said our training is great compared with other countries. Patrick has said the waves crashing over us. You know, if we allow the outside forces to dictate what we do, we're not behaving as professionals, saying we believe in what we believe in giving a good course of training. And Nigel's raised a very important point, which is worthwhile considering, which is that's why we're here, essentially. All these forces against us. Are we going to get rid of oral and get rid of dentistry or not? And we've got a lot of trainees here, and it's something they should consider. We've talked about it over and over again.
In fact, the theme of this meeting, if from my point of view, is how much we should be working with oral surgery and with the dental profession, and not the opposite. Right now, right at this moment, in 10 years' time, it may be different. But right now, my theme is to work with Colette. Colette's got a problem in delivering the service. It's all up in the air, and we are central to it. And my theme here is, although there's been a really rocky 5 years or 6 years within dentistry and MaxFac, that we shouldn't be colored by that. We should be big enough and strong enough to say, okay, fine, let that go. You know, great statesmen don't carry baggage. They move from one to another and just go. So my message is to listen to Colette, listen to what's going on, and say to you as young surgeons, there's huge advantages here coming through. It's a new world change, and actually just the opposite of that. I think we should be working with them, but whether we ultimately stay like it, I have no idea. There'll be lots of forces coming in years to come to change it, but right now...
Well, yeah, but right now is by the time a group of trainees is finished, 6 years is enough to have completely changed the landscape. What is very important is, what does anybody think is going to be there in 10 years? Let me come back to anybody think there's going to be general surgery? Is there help? There's going to be colorectal surgery, upper GI surgery, vascular's already left, urology and T&O left 20, 30 years ago. You know, the way life is. But what Mark and everybody should agree is that because you're working in the same anatomical region, you've got to be collaborating. And you can't work in an anatomical region unless you're fully trained in that region. And that's where I'm coming from, that if you want to train in that region, you should do your training, and then if you want to be there, do some enhanced training. But that's purely where I'm coming from. But I think, you know, just look at the whole of everything else, and we are becoming specialists.